What clinical features can set hay fever apart from COVID and asthma? What are some risk factors for developing melanoma? What key conditions do you need to be aware of in the summer months? Hello and welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Suchitra Krishnan, medical editor at MIMS Learning, and with me in the studio today are my colleagues.
Hello, I'm Pat Anderson.
I'm Rhiannon Ashman.
I can't believe we've come to the last episode of Season 3 already. We have some news to share. Pat, would you like to share the news?
Yeah, sure, I'd be delighted to. So our big news is that we've been shortlisted in the Best Science and Medical category of the Publisher Podcast Awards. And this award is open to publishing companies that produce podcasts. And it's described as a way to celebrate best practice and learn from the brightest in the industry, from magazines and newspapers to websites such as ours. So we're really delighted as we've been on a journey learning how to create and present our podcast and how to convey our learning points as effectively as possible.
Yeah, absolutely. We were all newbies to podcasting when we started this, so it's been great fun for us to learn about, and hopefully you've enjoyed listening too.
Yeah, and I have learned so much, and the process has been very rewarding. Reading all your positive comments and your constructive feedback on each episode is what keeps us inspired to keep producing more award-winning educational content.
Absolutely. So we'll let you know if we have any more news to share on that front.
Yeah, this reminds me actually that we have some more exciting changes to the podcast coming next season, which we'll tell you a bit more about at the end of this episode.
And in this episode, Rhiannon will interview consultant dermatologist Dr Suchitra Chinthapalli about melanoma, with tips for talking to your patients about risks and prevention, and we will conclude with key points on seasonal conditions that you would encounter in the summer months. But first, Rhiannon and Pat are going to compare notes on hay fever. Over to you.
Thank you, Sangeeta. So Rhiannon and I are going to discuss a module about hay fever. It seems timely to talk about this as we're recording in spring, leading up to peak hay fever season. Now, Rhiannon, you actually interviewed our expert, Professor Glenys Scadding, for this module. Can you tell me a bit about her?
Yes, so this is a webinar that I recorded a little while ago, but which is still valid now, I think. So Professor Scadding is Honorary Consultant in Allergy and Rhinology at the Royal National Throat, Nose and Ear Hospital here in London. I put a few questions to her that may be on GPs' radars. Firstly, how can clinicians differentiate hay fever from other respiratory conditions like asthma or COVID? Pat, what were the key learning points that you picked up from watching the webinar?
Well, according to Professor Scadding, there is quite a bit of overlap, and she's done a really useful diagram, sort of Venn diagram of seasonal allergic rhinitis versus COVID-19. And in the middle, where the two circles interlap, there's a nasal blockage, there's watery discharge from the nose, and there's sneezing. So you get both of those with each of those conditions. But when you've got hay fever, it's more likely to affect the eyes. So you might get the itching, the redness, and watery eyes, and that makes it more likely to be hay fever. Whereas on the other side, fever, malaise, sudden loss of smell, dry cough, and possibly diarrhoea mean COVID's more likely. And asthma may have a similar profile to COVID-19, and it may involve wheezing, shortness of breath, cough, and not very much sputum production usually. So if the person is known to be atopic and to have hay fever, then asthma may be more likely. But Professor Scadding says do always test if COVID is suspected.
Thanks, Pat. So hay fever is generally thought to be a mild inconvenience, but are there any red flags to consider that could indicate you're actually dealing with something more serious?
Yes, Professor Scadding covers some red flags. She says that unilateral disease is rarely allergic, so watch out for that. If there's heavy bleeding, that should be looked at by an ENT surgeon. And the big one to look out for is orbital cellulitis, which is very severe, one very swollen, very painful eye, just one eye. That's an emergency, and that should go to A&E. And she points out that if symptoms of hay fever are really not responding to well-directed treatment, then referral to an ENT consultant might be advisable.
Yeah, and I'm going to come back to talk more about the management in a minute, but first of all, what are the key bits of advice that Professor Scadding had for patients on avoiding triggers?
Well, apparently sporting the Michael Jackson look is a good thing to do, where you put on a mask and sunglasses, and that helps to keep pollen out of your eyes and nose. There are also filters that go inside the nose, or you can put Vaseline inside the nose. Pollen goes up during the day and down at night. So if you have washing outside, bring it in before the air cools in the evening. That means you're not bringing pollen into your house. And if you've been out and about in grassy areas, then when you get home, having a shower and washing your hair can be really helpful.
Thank you. That's really useful tips. So, what were the tips on management of hay fever?
Within her slide set, Professor Scadding's got a really useful slide of kind of stepwise treatment options. So I'm just going to talk about the ones that are the more basic, and then if you want to know more about the more complicated ones, you need to come and look at the slide within the module. But basically at the start, you need to educate your patient, advise them to use their treatment regularly and to stay away from triggers. They can use saline spray, which is very useful to wash allergens away down the nose. That can be used regularly as a treatment, and it's very safe for infants, for older people, and for pregnant people. And you can even spit it out. She has a no-no. Intramuscular steroids should never be used for hay fever, as the risks outweigh the benefits, and Professor Scadding has seen some patients with really bad side effects. And on management, a nasal steroid or an antihistamine would be the starting point. The antihistamine could be oral or intranasal. And if somebody had, for example, skin rashes, then oral is better. Nasal corticosteroids can be remarkably effective, providing the person uses them correctly. Combination therapy can be really useful. And for more severe cases, there are other treatments, and that depends on the type of symptoms. So there's a really useful algorithm in the learning module that shows the stepwise treatment and where you can go once you start getting into the more complex treatments.
You mentioned correct use of nasal corticosteroids there, Pat. What was the advice about how patients should be using them most effectively?
So apparently you should look down, and then you should use the spray on the lateral wall of the nose and not press it into the septum, and you should not sniff the solution back. You should just let the solution rest there for 10 to 20 minutes. It's really important to keep it in the nose for that long. Regular use is essential, and it'll take a few days for the steroids to work. So a combination therapy of antihistamine plus steroid will give quicker relief.
So I said earlier about hay fever being a bit of a mild inconvenience, but of course it can be really bothersome for some patients. So what could GPs do if they've got a patient who is really worried about hay fever before a big event, for example?
If someone's really bothered about something like an exam or a wedding coming up, then they can have a few days of oral corticosteroid treatment beforehand in the run-up to the event, and that should be enough to get them over the event.
So a final question, which maybe GPs do get asked, is it true that eating local honey can help to reduce hay fever symptoms?
Well, apparently it might be that if you have very local honey, it would perhaps have the pollens from your local environment, and you might, if you had honey on your toast through the winter, you might be giving yourself autoimmunotherapy in the run-up to the spring and summer months, but it would have to be very local apparently. I'm not sure that Professor Scadding is entirely convinced, but she says that honey is nice anyway, so why not have it?
Thank you both for that insightful discussion and some very useful tips to take away. We now move on to our next segment, where Rhiannon is talking to Dr. Suchitra Chinthapalli on melanoma.
I'm really pleased to welcome our guest, Dr. Suchitra Chinthapalli, to the podcast. Suchitra is a consultant dermatologist at the Royal London Hospital. She specialises in all areas of dermatology, but has a particular interest in skin cancer. Suchitra is also our clinical advisor for dermatology at MIMS Learning. Welcome to the podcast, Suchitra.
Thank you. Thank you very much for the introduction.
So today, Suchitra and I are talking about melanoma. And what's the sort of state of play at the moment in the UK in terms of prevalence? Increasing, decreasing? What are we seeing?
Yeah, unfortunately, the rates are still rising for melanoma. And in this country, there's about 16,000 new cases a year. It's actually the fifth commonest cancer in the UK. And there's meant to be about 2,000 deaths a year from melanoma. So it is an important skin cancer for people to be aware of. And especially if it's caught early, the prognosis is really very good.
As I'm sat here in the studio, the sun is shining and it is that time of year. So we're going to be focusing on prevention. And I think most people know that, clinicians should be advising patients to wear sun protection.
Yeah, so sun protection is really important because we know the biggest risk factor for development of melanoma is exposure to UV radiation. And what's great is, I think over the years, there's been much more public health campaigns. So the public are much more aware of the importance of sun protection. Certainly, you see that in younger generations. So people in their 20s, 30s are already using high factor sunscreen that's protecting against UVA and UVB radiation. And I think also what you see more of now is that people are using the higher factor sunscreen. So rather than using an SPF 15 or something, they are just going straight for the SPF 30 or 50, which is more effective.
And is it something that GPs should be like routinely talking to their patients about? Is it something that's like that people should be wearing year round?
Yeah, so I definitely think it's something GPs should be talking to patients about, particularly the ones that they identify as being at higher risk. So, for example, people with light coloured hair, so kind of blonde hair, red hair, blue eyes, people with very fair skin that burns easily, and those kind of people are at higher risk of melanoma. And certainly, I would focus on giving them information on sun protection and preventing burning. Um, but there is a much bigger trend for even those with darker skin types. So people even with my skin types, I've an Asian skin type, and darker still using sun protection. It's not that clear there's actually that bigger role in it preventing melanoma as such, but it certainly helps reduce skin aging. And for that reason alone, it's very important, even if it's a bit controversial as to how much of an impact it has on the development of skin cancer and darker skin tones.
I want to come back to ask you about risk factors again in a minute, but I'll pick up on what you were talking about people with darker skin tones and advice around sun protection. I wonder what the sort of tailored advice needs to be for patients with darker skin as well around spotting skin changes, that might indicate melanoma.
Yeah, so I think now, certainly in dermatology, we have a lot more emphasis on people with skin of color and skin diseases we see in them, and recognizing that she can be quite different to other skin types, which is really great to see. And certainly, an important thing for people to realize is that although it's a lot less common, you do still get skin cancer in people with darker skin types. And actually, what we tend to see is they're more likely to get, for example, a melanoma on the nails. So it's important to realize you can get nail melanomas. I always say someone famous who had a nail melanoma was Bob Marley, who died at the age of 36 due to metastatic melanoma. But also on the palms and the soles of the feet are the common areas where um, you see melanoma a bit more commonly in darker skin types. And even other skin cancers like squamous cell and basal cell skin cancers, you do still see them. And for example, basal cell skin cancer more likely to be pigmented in those with darker skin types.
That's interesting. So it might be the case as well that clinicians need to consider advising their patients who've got darker skin that you might sort of see skin cancers in like areas that you wouldn't normally expect, like you're saying, the soles of the feet and the palms of the hands.
And I think that's really important because, especially if you think about soles of the feet, it's not somewhere that people normally look. And even though it's important in people with skin of colour to look at those sites, what's important to realise is, regardless of what skin type you have, anyone can get it on the soles of the feet. So for everyone, that's an important place to just remember, and in between toes, and nails as well. Nails in particular, I think, is an interesting one because I think it's quite easy to delay seeing someone thinking, oh, I must have just hurt myself, or maybe it's from poor footwear or something like that. But if you're not sure, it's worth just getting it checked out.
So what sort of nail changes would we be looking for?
Yeah, so the common one is you get a longitudinal line of pigment down the nail, almost like a stripe. And that's a common finding. Sometimes you can see that the distal end, so the far end of the nail, might just break a little bit. Um, and occasionally, so that's about 2/3 of cases, and about a third of cases, you may just get a lump developing. And especially if you get a lump that doesn't have a brown pigment or anything like that, it's easy to think, oh, maybe it's a wart, maybe it's something else. But that's worth having a look at, having someone take a look at as well.
Thanks. Moving back towards the risk factors that we were talking about earlier, obviously we've talked about UV radiation being a big risk factor in melanoma. What are the other risk factors that we need to bear in mind?
Genetics, like with most conditions nowadays, there's always some element of genetic predisposition. And so often when we're speaking to patients, we'll want to know, is there a family history of melanoma? Um, so that's a big one. The skin type, which is partly genetic as well. And then other things that are really quite important for us is to know their sunburn history. So have they lived abroad somewhere really hot, such as Australia or New Zealand? And particularly we're interested at their age. So if they were born and brought up there, then that's probably going to have more effect than, say, if they moved there in their 60s, because the sun exposure you get when you're younger seems to have more of an impact. And looking at sunburn episodes, the other big thing I think is use of suntan beds. So I still ask everyone who comes for a mole check, have you used tanning beds? Even if they're not currently using them, it's still relevant if they used them 20 years ago or 30 years ago.
Do you still see patients who are regularly using tanning beds?
Yeah, it's not that frequently, but it is surprising. You do still get people who use them, and quite a lot of the time, I find that the commonest reason is actually they want to just get a bit of a base tan before they go on holiday, which I think really, yeah, I wouldn't recommend, because there's no such thing as a safe tan. Um, Tanning is basically just your body's response to try and protect itself from further damage. But the tan itself indicates that there's been damage to your skin.
I think there is a common misconception, isn't there, that it's safer to get a base tan and then you're less likely to sunburn.
Yeah, exactly. I mean, the reality is all tanning is damage to your skin to some degree or not. So that's something for people to know, and also to know that actually going out, say during the daytime in sunlight, is safer than using a tanning bed. I think the particular concern is when some people have tanning beds at home, because then I think you end up using them a lot. I mean, it's interesting because some countries have banned tanning beds completely, such as Australia, New Zealand, and places like the UK, we still allow tanning, but as long as you're over the age of 18. Um, but I'm not sure there's a huge benefit to tanning beds nowadays, because if you're looking for a fake tan, if you're looking for a tan, you can use fake tan products such as the creams and the lotions, which are pretty good and they're safe. So, in a recent research briefing, I actually discussed tanning beds. There was a really interesting article from a German group who looked at the behaviors of people who use tanning beds and why they used them. So, other than wanting a base tan, quite a few of them mentioned that they thought getting vitamin D would be beneficial as well. But again, if you're really bothered about getting vitamin D, natural sunlight is a much better source, because it comes from UVB radiation, which you get more in natural sunlight compared to tanning beds, which tend to have more UVA. But the other thing also is vitamin D is quite easy to supplement. So I'm not suggesting people should kind of completely cover up and not go out at all in sunlight, but I think particularly those who are at high risk of skin cancers, it's worth them just thinking about their behavior in terms of using protective clothing, using sunblock, avoiding peak sunlight hours, to kind of say between 12 and 3. The other important thing to highlight to people is that tanning beds are actually considered a carcinogen, and the World Health Organization has classified them as such. And I think if people knew that, it would make them think twice about whether to use a tanning bed. And that research article that I'd recently discussed in the briefing also talks about the fact that, worryingly, tanning beds are now being seen more in health and well-being facilities. So it might give people this perception that actually this is part of your health and well-being, and they're really not.
So, talking again about sort of sun protection, have you got any like key pieces of advice that you give to your patients?
Yeah, so I tend to recommend protective clothing, um, because the best bit about protective clothing is once you put it on, that's it. You don't need to reapply or do anything else. And thinking, particularly of long sleeve clothing, but also particularly in men who often are more likely to have loss of hair on the scalp, to make sure they protect the scalp. So I think hats are really important. And I think often you see men wearing baseball caps, but I always say try and go for those kind of wide rimmed bowler type hats, which hopefully people see as being more fashionable, because that rim just helps protect the back of the neck as well, and the sides, and the ears, which is really important. So I think hats, long sleeve clothing. The other big thing I say is people who do a lot of water sports or skiing to remember quite a lot of UV radiation is reflected off water and snow. And I think that's an easy time to forget about wearing sunblock, say if you're going on a winter skiing break. And also when you're doing water sports, uh, unless you get a really good water resistant sunblock, you're going to have to constantly reapply. So that's kind of the clothing aspect. And then the other aspect is using something like a sunscreen. So I tend to say get something that protects against UVA and UVB. So UVA, you'll often see a star rating on the bottle, and for UVB, you're looking at your SPF rating.
So, if a patient asks you what should they be looking out for in terms of melanoma, what would you say to them?
So I think the first thing is to become familiar with their own skin. I think they need to um, get into the habit of just checking their skin. And I tend to say to people, just every 4 months or so, just when they're in the shower, just taking a quick look and thinking, okay, these are the moles I have, and just registering them. Because then if a new one pops up or one changes, they're more likely to pick it up. And then a particular area that I always say to everyone is make sure you also include the back, um, because often there are quite a lot of melanomas that appear on the back and they're diagnosed late because it's only when someone else sees them and points them out. Um, and then in terms of the moles themselves, we often give the kind of ABCD criteria, and I think that's still very valid. So I say to them, look to see if the mole is asymmetrical. Has it got a little bit sticking out on one end? Has the border changed? Has the color changed? Is there more than two or three colors? Has it suddenly become darker? Um, the diameter for D, is it getting larger? Um, was it half a centimeter a year ago, and is it now a centimeter? And then also E is just for evolution, just the fact that it's changing. So I think that's important, and to realize that melanoma can come from an existing mole that's changing or a new mole that's developed on the skin.
Do you ever recommend that your patients like photograph their own moles to keep track of them?
Yeah, definitely. So I'll often say to people, you don't need really close up photos. You just need some, even from far distance, that you can zoom in. And I think cameras on your phones are absolutely fine for this. And just zooming in, particularly with the back, and just almost doing a spot the difference and thinking, oh, this was there, this wasn't. And I say to a lot of people, I think there's a term known as the ugly duckling sign that we use. And the point is it the odd one out for them is basically what we mean by that, because sometimes people have lots of funny looking moles. There are some people who have kind of say more than 100 moles and they all look a bit funny. What we're really interested in is this normal for that patient? Has there been any change? Is it the odd one out? And that helps us decide on whether we may want to take that mole out to get it checked for histology.
Okay, so to round up then, and to leave our listeners with some kind of key take-home points on diagnosing melanoma, what are the key pitfalls that you would say for them to avoid?
I think the first one is try and do a full skin examination if possible, because it's very hard to treat a mole in isolation. You need to know what the rest of the moles look like. Second is remember that not all melanomas are pigmented. Some of the more aggressive melanomas are amelanotic, i.e. they have no pigment network and they might just be skin-coloured, fast-growing nodules. And so I tend to say if you see something that's rapidly growing or changing and you're uncertain what it is, it's still worth referring in, because it may be an unusual type of melanoma or another type of skin cancer, which is rarer but can be quite aggressive, such as a Merkel cell skin cancer as well. And the third thing is, I think, patient education. I think that's really important, very hard in 10, 15-minute appointment slots. And that's where directing them to websites such as British Association of Dermatology, American Academy of Dermatology is really good because they have lots of videos on how to check your skin and lots of information, not just on melanoma, but on squamous cell and basal cell skin cancers as well.
And we're back for our 3 key points on conditions related to hot weather and holidays, specifically Lyme disease, diarrhea, and fever in adults. So, Rhiannon, what's our first key point?
Our first key point, taken from a module on red flag symptoms in erythema, is that the incubation period for Lyme disease may be 3 to 30 days after a tick bite, or possibly after the inappropriate removal of an infective tick. Now, we're all probably familiar with the hallmark bullseye rash in Lyme disease, but Dr. Tilman Jacoby, the author of this module, adds that the rash is often located on the limbs and doesn't tend to hurt or itch, but it can feel warm to the touch. The red flag for Lyme disease is the presence of additional intermittent flu-like symptoms, body aches and swollen glands, that sort of thing.
And our second key point is?
So our second key point is on diarrhea. And in a red flags module on this topic, Dr. Pipin Singh says that a history of foreign travel and a history of eating out are both red flags to consider in a patient with diarrhea. If you're submitting a stool sample for culture and sensitivity, you should ensure the laboratory is aware of any recent travel or eating out. And it may be appropriate to submit 3 samples on 3 consecutive days to ensure the best chance of detecting a pathogen. And of course, diarrhea can be particularly worrisome during the hotter months, and dehydration could be a problem. Dr. Singh adds that your examination should include an assessment of the patient's hydration status, so check their mucous membranes and their skin turgor, and whether their eyes might look sunken.
And our final key point is on fever in adults, which has a broad range of differentials. A history of foreign travel is a red flag in an adult with a fever. As you know, fever is defined as temperature of more than 37.2 degrees centigrade and can be graded into low, intermediate, or severe, with severe pyrexia being defined as a temperature of more than 40 degrees. But interestingly, temperatures of less than 36 degrees should also alert the clinician to infective pathology. With any history of foreign travel, you would be particularly wary of tropical infections such as malaria, and in a patient with fever and recent travel, a full blood count would not be unreasonable to assess blood cells and establish a baseline white cell count. And that concludes our 3 key points. Rhiannon, you mentioned something about changes to our podcast. Would you like to tell our listeners a little bit more about that?
Oh, yeah, absolutely. Well, we always strive to make the podcast more enjoyable and educational for our listeners. So from next month, from season 4, we'll be releasing a new episode weekly. So double the dose of the Clinical Update podcast for our listeners. We'll alternate between bite-sized studio episodes where the MIMS Learning editors will provide you with key learning points and longer form interviews with experts to leave you with in-depth insight into the latest developments.
I'm very excited about this, and one thing I'm looking forward to is that we'll have different clinical themes for each episode so we can delve deeply into the issues.
Yeah, I'm looking forward to it as well. Thanks very much for joining us on this episode and for being with us during Season 3. You can find links to all the topics discussed in the podcast notes, and don't forget you can claim CPD for this episode on the MIMS Learning website. We very much look forward to the next season, where we will return with more clinical education for you. See you next time.